Good evening, everybody. Thank you for joining this webinar. I welcome you, our professors and our colleagues from Gulf countries, from Egypt, from Nigeria, from Pakistan, from Bangladesh, from India. In this webinar organized by Oman Society of Nephrology and Transplantation and sponsored by Amgen Group. Title of webinar is Anemia Management in Chronic Kidney Disease. I am Dr. Ahmed Atris Amir, consultant nephrology and head of department in CKD Renal Center in Muscat. I am the moderator, and our speaker today, two excellent nephrologists. First speaker, Professor Muhammad Rouhani, Associated Professor of Nephrology in Ras Al Khaimah Medical and Health Science University. He will speak about optimizing the anemia management in CKD. And second speaker, Dr. Fadi Magdi Ilyas, consultant nephrology in Boucher Renal Center in Muscat, and active member of Board of Oman Society of Nephrology and Transplantation. He will speak about personalized anemia care in CKD. Our chairperson of webinar is Professor Raisa Salim Salmi, senior consultant and chairperson of Oman Society of Nephrology and Transplantation. He will discuss your questions with the speakers. Now I will give a short introduction about anemia in CKD.
Recording in progress.
Anemia is common and significant complication of CKD, especially in moderate to advanced stage from 3B to 5. It is primarily caused by decrease in erythropoietin production, but also may be affected by other factors like iron deficiency, chronic inflammation, short RBC's lifespan, and blood loss, especially in hemodialysis patients. Anemia in CKD associated with fatigue, decreased quality of life, increased cardiovascular morbidity and mortality. So early detection and the proper management are essential in care of CKD patients. Dear attendee, please send your questions at the end of each lecture in chat to can answer and discuss with our professors. And now we'll start with the first speaker, Professor Muhammad Rouhani. Please, Professor Muhammad.
مساء الخير جميعا، السلام عليكم ورحمة الله. أنا طبعا سعيد جدا أنه أكون معكم، وفي هذه الحقيقة كوكبة من الدكاترة المحترمين والناس الكبار اللي اعتز بوجودي معهم. وحسمح لنفسي قبل ما أبدأ بالمحاضرة أقول أنه أنا رتبت المحاضرة بشكل بسيط وسمبل، على أساس أن احنا بنتكلم على جزئية. Okay, I'm sorry, I forget to speak in English, and I think most of us speaking English. And the agenda is prepared in that way to simplify the issue and to go from the basic to some step. And it is directed about the darbepoetin, and sponsored by Amgen, but they did not interfere to the slide and to the quality of slide. So any drop in the slide, it is my own decision. But I make it easy for us to remind all of us about the issue of anemia in CKD and how basically can be treated. As you see from the agenda, we have a lot of issue, and we will go directly. Basically, we'll start anything with the definition of anemia, and defining anemia is simply by low hemoglobin in male less than 13 gram per deciliter.
Before they do progress into end-stage renal disease requiring dialysis, and this is because of the cardiovascular problems. Next, Sandy. So what we're going to deal about is one of the complications of chronic kidney disease through different stages.
I have another voice. Brother, I have like Somebody else speaking?
Dr. Muhammad is yours. خلاص, I muted all.
Okay. And the important also not to forget children, despite I'm not a pediatric nephrology, but adult nephrology. But this number of low hemoglobin is general with all type of anemia. Now, when we are speaking about the complexity of anemia in renal failure, we cannot forget the role of the kidney bone and bone marrow and the endocrine regulation of erythropoiesis through production of erythropoietin from the kidney affected and stimulated by hypoxia. The hypoxia can be decreased due to many causes, but mainly stimulating the bone marrow to increase the number of red blood cells and to create more hemoglobin. And by that issue, we can tell that hypoxia will affect the kidney, and from the kidney, the erythropoietin will be released to the bone marrow, and with the existence of component of iron, vitamin B12, folic acid, and other, the red blood cell can be rebuilt. But we cannot forget another issue. It is hypoxia inducible factor, which now is a popular issue in the new version of management of anemia. But because it is not our issue for tonight, I will not go detail in that issue. We know very well that complexity of end-stage renal failure started and developed over a period of time, depends on the cause, take years, or it can take weeks and months to develop to the end-stage renal failure. And during that journey of the disease, we can tell it, we are observing many complications, including anemia. And anemia is an important issue in such level of serum creatinine. And if we will go back to the level of creatinine, we can tell if the patient in grade 3 or more than 4 milligram per deciliter, the existence of anemia below 10 is higher. But we can look to that exactly from these slides prepared many years ago, more than 22 years, and looking to the relationship between the serum creatinine and the level of drop in hemoglobin in women and men. And it is clear that if the serum creatinine below 20, it is clear that the women are affected by drop of the hemoglobin significantly, but this significance can occur even earlier when the estimated GFR less around 30 or less. Same as in the male, it is a similar number, but the male are affected more by the drop of the hemoglobin. So the relationship between increment of serum creatinine and the occurrence of hemoglobin drop is clearly mentioned in this trial. And from that, it came where we are, what's going on in these. And they try to tell that, okay, the iron and the erythropoietin are important for the metabolism, and how to manage these. And they look also to the hepcidin in the pathophysiology and development of anemia, and the regulation of anemia as endocrine issue, as also supplementation of substance, as well as managing the hypoxia. In this matter, I want to jump directly to new issue, what it is the relationship between anemia and cardiorenal syndrome, and we'll go back to the essential. We can see that anemia is part of the cardiorenal syndrome, and I think many of us agree that when the hemoglobin drop, the severity of the ischemia in whole the body, including cardiac, including kidney, including brain, is deteriorating, and correcting of anemia can improve the outcome. I agree with any comment that the drop of hemoglobin is associating with increase of serum creatinine, and correcting of hemoglobin is also associated with better improvement in creatinine, since we are not speaking about chronic stabilized level of CKD. And from that, we agree that these issues still need to be more studied and more deep look to that. But anemia basically can cause tissue hypoxia, and tissue hypoxia can lead to the blood pressure defect and regulated by RAS system and affected by RASi medication, as well as in the central nervous system, affecting the kidney. In other hand, also the level of oxygen will affect the heart failure and lead to the left ventricular overload, overwork, tension, to increase the need of the other organ for the oxygen, and which lead by slowly by these overload and left ventricular hypertrophy or dilatation to the heart failure. Another issue what I want to touch here is the anemia associated with end-stage renal failure also can cause an increase of all-cause mortality. And from this trial have been done and studied around 4,000 patients. It showed that anemia was independently associated with increased risk of incident in stage renal failure, and future work need to be evaluated for the role of anemia in the CKD state. We are learning daily exactly how to go to issue and how to go to the deep issue. Until now, we know that many causes, as Dr. Ahmed told, it is relative erythropoiesis deficiency, it is iron deficiency, it is the blood loss for the patient in dialysis. They have searched and blood loss during the dialysis itself, despite of the development of technology, and reduce erythropoietin survival duration less than 120 days, or and sometimes below even 90 days, inflammation process, infection, and all these causes lead us to think about the complexity of the issue, and also to look if a matter of really it is pure related to the drop of the level of erythropoietin, or combined by other complications. The most important here is the iron deficiency, but not limited to that. We have to look to the B12 level and folic acid as well. As tonight we will discuss the absolute and real malnutrition and poor absorption of iron as clear iron deficiency, or the decrease of the production of erythropoietin. And if we look to the loss of blood in the healthy patient and non-dialyzed and hemodialyzed, we will find it increasing. Depends, because non-dialyzed patient, it is a frequent sampling test. It is also not to forget that the absorption of substance helping in the breathing of hemoglobin affected as well. And we cannot also forget that in hemodialysis patient, we are affected by the type of bloodline in the machine, by the type of the dialyzers, and the malnutrition syndrome that occurred due to dialysis. Nowadays, it changed from in dialysis patient from limited source of iron to open label somehow about the iron consuming. And also we cannot forget the function iron deficiency. These functional and absolute can be divided into chapter as here, and from this figure we can look how it is affected by either direct plus loss, depletion of the stores, lack of absorption, or functionally by the liver factor transferrin or TSAT or ferritin level, and the replacement of ESA. To simplify the issue, if I have a patient with estimated GFR 35 diabetic and the hemoglobin is 8.5, persist for 3 months with all the symptoms already mentioned by our colleague, we have to look about what exactly is the level of ferritin or transferrin saturation of normal or B12. If we have some drop rather than ferritin below 50 nanogram per milliliter or total saturation less than 20, we can speak about the iron deficiency. Why I am focusing in the iron deficiency? Because correcting the iron in the beginning or during all the process of renal replacement therapy is an important cornerstone, and we have to look to that, how it is better. Of course, most of us agree that intravenous iron is acceptable if the patient cannot tolerate, or we understand that the absorption of iron from the GI is slower, and we need such level, what we'll speak about it, to reach and to see. But we cannot forget that the disadvantage of the iron infusion also can be mentioned. However, these inflammation process or oxidative stress or anaphylaxia can occur. In other side, we have a greater hemoglobin correction, reduce the ESA need, as we know, and the important to reduce the transfusion need. Now, when this started, I think many of us here, they still remember the time when we start with EPO-18, and we, in some country, mainly the rich country, we started in that time from 10,000 units until the hemoglobin corrected. Then we dropped to 5,000 or 6,000 to maintain the level, and that was associated with many issues and complications.
Next is Cindy.
And
So as you can see, this is the main difference between
four major studies from 1998 until 2009 discuss the issue, which level we have to reach and which is our target. And we agree about that which is the marker as well. Should we look to the hematocrit as a marker or the level of the hemoglobin, and which level? This consideration lead us to make as a strategic look anemia management. Should we started with the ESA as a high dose or iron, and which harm it can be? Should we look to the cardiovascular in that? What's the novel therapy to reduce the risk? Is low dose of ESA is better than high dose? And exactly what the nowadays, what's the role of other medication? Now, from this study, we reached to a level of discussion that overcorrecting the hemoglobin is associated with cardiovascular complication, mainly left ventricular remodulation, increase the risk of cardiovascular death. And the most important in dialysis patient is the clot of AF fistula or graft, okay, and increase risk of losing the vascular access. So if we are above 12.5 or above 13, this risk is clear. And if we are below 10, and the symptoms of anemia can occur. Okay.
Sorry for interruption, but new doctors joining, everyone has an open mic. This is why the interruption. Continue.
No
I am
problem.
trying. I am follow up with you.
We will be resistant. Don't worry.
Okay,
These are nice, but good that they are enjoying. I'm really happy, and I think all of us are happy to have all these interests. Okay, but at the end of the day, when we reach what's going on, the KDIGO came with the guidelines in 2012 I mean, before 13 years, until the optimal level of hemoglobin, which we should reach is 10 to 11.5. Below 10, we'll have symptoms of anemia, and above 11.5 or 12, the risk of cardiovascular complication is high. Our target not to be in anemia, our target not to be overdoses, and also they guide us exactly how to avoid the transfusion need in this patient. We all know that the transfusion is associated with sensation problem. From these discussion, sensation and transplantation, sensibilization and the transplantation issue, and blocking the transplantation, as we all know that. So the greater level we reach, it is between 10 until 13, but with 13 we are already facing a issue with all cause of morbidity and mortality, and the best thing is 11.5 maximum to 12. Now, the anemia itself in the mortality side is affected by the comorbidity, not only anemia in this group, and increase with the coexistence of disease, but anemia is also important to look to that level, and which we have to reduce the risk of complication. Again, high mortality was associated with anemia in many trials, showing which number or which level of hemoglobin can increase. With more drop of the level of the hemoglobin, the mortality is high, below 9. Now I will go to the darbepoetin issue, and from the darbepoetin issue, the thing came, should we start directly with darbepoetin in CKD, high dose or low dose? And they studied darbepoetin alpha, and they compare to the low hemoglobin and high hemoglobin, and they come to the same conclusion that low hemoglobin is not different from high in the aim of targeting the hemoglobin, and they reach totally that 11 gram per deciliter with darbepoetin is the best way, and more than these is not going to change the outcome if we reach it. And the best way is to reach here, they tell between 9 and 11, but the guidelines is strict to be 10 or not. There's another also issue. What's the difference of the hemoglobin with higher or the lower? And they found these kidney composite outcome is the same. Initiation or maintenance of dialysis treatment is the same. Reduction of 50% of estimated GFR, it is the same. And reduction of estimated GFR by 6 milliliter per minute also or less is the same. But before I will go to these, I want to remember a theory when the people is telling, okay, if I don't need muscle, the patient is bedridden, for example, and the activity is low, how much hemoglobin I can tolerate it below? These not guided, not but some people, they are tolerated to drop it even to 9, because we know that the muscle, the patient is bedridden and he doesn't have that much activity. On other hand, I don't know if I can, yeah. We learn from the KDIGO. What happened to KDIGO? That initiation of ESA, including, we have to look to the whole issue, iron deficiency, inflammatory process. We know with the inflammation, the response to ESA is not adequate, but look to the quality of the evaluation. It is either not graded, or it is too Rarely it is 1, and if it is 1, it is most probably 1B or 1C, okay? And here, like initiation and maintaining ESA therapy, we recommend balancing the potential benefits of reducing blood transfusion and anemia-related syndrome against the risk of harm in individual patients like stroke, vascular access loss, and hypertension. These, and I will add to that somehow the hyperkalemia as well. Again, for the adult non-dialysis patient, we have to target the hemoglobin above the 10 by management of ESA or controlling it by component like iron. In the second slide, they told us that CKD non-dialysis patient with hemoglobin concentration less than 10, we should get that to the decision of initiation of the therapy to be individualized based of the fall of the hemoglobin concentration. That means I have to look how much is the fall, and I will look to the need of correction of that hemoglobin by ESA as well. And hemodialysis patient in stage 5, we suggested ESA therapy to keep the hemoglobin above 9, and between 9 and 10 is better way. There's another, but also it is 2B. So the evidence and the value of the guidelines KDIGO was either not graded or low grade level. These are really a lot of talk there about this policy, and it is old. It needs to be re-evaluated. And I think the re-evaluation is coming from the KDIGO by year, especially the last year, in the direction of the new trials and the new existent medication. Also, maintenance therapy of ESA should be concerning the patient with CKD not to cross above 11.5 and to keep the range of the hemoglobin again in the level, what I think we all agree between 10 and 12. But again, the evidence level is not well, except in all patients, we recommend ESA not to be used if the hemoglobin concentration above 13, and not to start, I think, if the hemoglobin above 10 in other chapter, yani, okay? In other hand, it's the same comment here and the same grade. I'm just illustrating the KDIGO because it is our Bible in the end of the day, but also the grade and the strength of the evidence is not that much leading us to the strong evidence like other finding or other clinical trials nowadays. The FDA warning the use of ESA if above the target of 11, because the risk factor of cardiovascular doses and patient with CKD of hemoglobin above, we should not start ESA, and patient with CKD on dialysis, we have to maintain hemoglobin and not to cross above 11. Not only the risk of cardiovascular, but as well the vascular access complication, what is for us nephrologists and dialysis team, it is complicated issue. Now, why we have to choose RNSP? RNSP, for me, I started with all type of I remember from the middle and the end of years of 90s last century, we started with epoprotein, we started with the and when the RNSP came, or it was like a solution for the staff nurse and solution for the frequency of giving, especially if we decide to give it subcutaneous. Okay, it was a wonderful. It is a matter of 1 times per week. After that, we learn it is 2 times per week, 2 weeks, 1 time per 2 weeks, and finally we reached that it is even monthly can be covered 1 time. So it was like making the life easy and reaching the same target and avoiding another fluctuation of the level of hemoglobin with the half-life of epoetin. So, and reducing the need of higher dose, and this from the economical point of view is important. But iron deficiency is a corner study, as we told, and we have to remember that ESA, all the ESA, including darbepoetin, has a problem if we have malnutrition, infection, or hyperparathyroidism as a response in the let us to tell the factory of erythropoiesis. In other hand, I will put all these. The flexibility of the darbepoetin, as we told, it is from once weekly until once monthly. It is easy to be given and really helping the staff nurse and even for the doctor for ordering the medication. However, it is also give me a flexibility. If it is not fixed only 1 month, and it is not fixed only 1 week. If I need to increase it during this month, due to any cause lead to the reduction of the hemoglobin, I have flexibility to change the regime and the time or table of the dosage or injection in the month itself. And a study on 4 million with darbepoetin use lead to this conclusion, and correction of anemia can be once weekly, as we thought, can be twice weekly, can be once, but most probably in the once monthly, it is most probably it is a matter of maintenance. And the dosage, as it is mentioned here, how much per kg, we know that we are using it, how much per standard dose, like 20, sometimes it is 20 enough microgram per kg, microgram per body weight for 1 month totally. I have experience with that even 20 is enough since the hemoglobin, and sometimes in the patient not yet in dialysis, and some level of erythropoietin, endogenous erythropoietin, can still be there, we are able to reduce the amount of the need. For adult also, as we told that to start RNS as any other if the hemoglobin less than 10, and it is recommended to increase the dose or to give it as we used to give it for our patient, and also to increase the level of the hemoglobin above 10 and not to be less than 10. And when I will reach the 10, I have to look to the dosage and to adjust it accordingly, and I have a chance to reduce the dose again to keep the maintenance. For all patients with CKD, if the hemoglobin rapidly deteriorated more than 1 milligram, if any 2 weeks period, rise first of all, I can reduce it, the dose of the darbepoetin, and by 25%. If the hemoglobin continue to rise even after increasing, I have a chance again to decrease more until I can see that the hemoglobin in the plateau or slightly he start to be decreased. Then I will keep the range between 10 and 11.5. For not responder or the hemoglobin not increase, I can increase, and this defined as 1 gram per deciliter after 4 weeks, after 1 month. I can increase the dose again by 25%. and to observe if there is no other cause of medication or not iron or vitamin B12 or other cause of inflammation can cause non-responsiveness. This is a comparison study between the darbepoetin and the other medication, and this for the once monthly study. They study it in patient who is it is all trial. It is from 2024, 11 years ago. But they study it in the patient young, older than 18 years, clinically stable, estimated GFR, still not in dialysis, hemoglobin less than 10, and adequate iron store, and they put them on darbepoetin Q2 weeks or Q month, and they find the primary outcome, how much the change will be observed, and other point to achieve hemoglobin 10, and the time of achieving, how long we need the time until we reach the level, and how's the safety data. There is a talk about Misera. We tried to use the Misera. The issue of the Misera is fixed dose per month. They tried to explain us after that it is we can use it 15 days, but it looks like we have it for 1 month. We can increase the dose, and we have no flexibility in the protocol to go. At least is my experience and our center experience, and the other center observed here, and not to go to the level that, and also the cost is issue. I will not go to all the things because I'm not totally against Misera. A study showed those saving when use darbepoetin or erythropoietin, this economical issue, and efficacy of cost also there by the darbepoetin or Misera also there. It's also economical issue. Erythropoiesis, hyperresponsiveness, it can be a lot of cause: iron deficiency, vitamin D deficiency, folic acid, hypothyroidism, RASi blocker level, infection, inflammatory, hyperparathyroidism, under dialysis, the KT overfeed is not reaching the target, more lost clot in the dialysis extracorporeal part component, and so on. In conclusion, we have to remember, all of us, that the anemia is a complication what occur with the deterioration of renal function. It is multifactorial and need a holistic approach, and the diagnosis of anemia should be related to end-stage renal failure. We should exclude another cause of anemia, mainly the iron deficiency, and we can treat it. And I don't know if we can really clearly define and find a barrier between iron deficiency, anemia, and CKD, and CKD related to erythropoietin directly, correcting of hemoglobin by use of iron and EC is the cornerstone. And as we told, this multifactorial iron status is important. The level of the hemoglobin should be between 10 and 11.5. And I don't think that I have to go to detail. I think all of you, this conclusion, you know it. Thank you so much, brother, and willing to take any question if you like.
Thank you, Professor Muhammad, for this informative lecture. And we have many questions in the chat. We'll start with first one. Patient with high ferritin and low or normal TSAT. Which one we follow for iron deficiency?
Now we have to look, the high ferritin is a marker of inflammatory process. So we have to look if there is these increase is related to some infection in the patient or not. This is an important part. If I have TSAT low than 20, I will follow the TSAT rather than the level of the ferritin alone. The target of the iron, I will the target of the ferritin, there is many trials. And in dialysis, they told us that below 700, okay, it is acceptable, or 650, it is acceptable to avoid and to increase the hemoglobin rather. But we have to look there. The patient on dialysis, they are in inflammatory reaction in each dialysis because of extracorporeal. So the level of the C-reactive protein is mildly elevated, not only because of the CKD, but also with the existence of compound, and to look to the erythropoietin, to the ferritin with conscious.
Okay, Prof. Other question, what is the concept about hemoglobin more than 12 in hemodialysis patient with fistula or graft?
Okay, now, all the medication correcting the anemia, injectable or non-injectable, including the new medication of HIF factors inhibitors, is associated with increase of level of hemoglobin and increasing the viscosity of the blood, leading to the risk of thrombosis. This thrombosis can be anywhere, but the AV fistula is the like a leader for us, and it is there. Okay, but also can be another risk in the brain with a stroke, thrombosis. Okay, peripheral deep vein thrombosis also can be. Depends from patient to patient. So the viscosity and increase the hemoglobin number and the red blood cell number is associated. Also, we have to remember that the development of erythropoietin of anemia in CKD take a long time. Now the rapid correction of the what we learn from the high dose of erythropoietin is leading to the load on the heart itself, as we told, leading to the possibility of heart failure. Also, the ESA can affect and remodulated the mass of the left ventricular hypertrophy and hold the ventricular hypertrophy, leading to hypertrophy.
Clear, Prof. Another question, what is the maximum dose of aranesp? And there is difference between route of injection, IV or subcutaneous?
Now, in the reality, we are using it in the end of the dialysis to the circulation in the, okay. And from the clinical trial, we know that the absorption of the subcutaneous is slower and prolong the effect. That was clear with the epopoietin. With the darbepoietin, it is 1 week or 1 month. It is different, even if we give it intravenous. But still, we are strict with the clinical trial, telling yes, there is some superiority, despite some minor trial showing that there is no superiority.
Also, another question regarding patient with iron deficiency anemia. We should search about cause like doing OGD, upper OGD, or others.
Now, first of all, if I have anemic patient, I will look to that from all the aspects, even if it is with CKD, possible, especially for our area, thalassemia, G6PD deficiency, and so on, and hemolysis, criticals. This is one thing. The other thing, our patients are complicated cases, especially in the stage 4 and in the stage 5 for the cardiovascular disease. And they are using sometimes really, we are in horrible condition when you find aspirin, clopidogrel, enoxaparin, okay? And even during the dialysis, heparin. I don't know. I saw one patient 3 days ago, which leading to bleeding from the GI and reducing, of course, the hemoglobin. The importance of doing endoscopy is depend on the individual finding. So yes, I will go and I will see if there is ulceration, if there is erosion of that. How is this case in need, particularly not with every patient?
Last question, Professor Muhammad, about roxadustat, if it is better than ESA or not, and if it is better, why we not use the dialysis patient?
First of all, we can use roxadustat. There is a trial to be used in the dialysis. I am sorry for Amgen, they will kill me tonight. Okay, but okay, let us to look to the level of the evidence. It is good. It is popular. Everybody took it. I have my experience with roxadustat in our patient. We started in non-dialysis patient and failed the stat. They approved it FDA in 3 months after starting dialysis. Now the approval in dialysis itself, we have to remember that the anemia started with the CKD before. If we choose for the patient to start with the darbepoetin or other ESA, the question will come, why I should change it to the tablet? But if I start tablet, there is no strong evidence until now or strong recommendation from many guidelines, except in China and Japan and some centers in Germany and Italy. Even the Italian, they are not much strong to tell, yes, we can replace it 100% for 2 reasons. The first reason is the same complication. The second reason, the roxadustat, when they start, they try to approve that this medication is good to correct the hemoglobin. Then they start with high dose. And the high dose was associating with overcorrection of the hemoglobin and lead to the complication faster. That's true. Okay. When they compare it to the ESA and mainly to the darbepoetin, there is no differentiation in the side effect and the complication. So it is a matter. I have patients who told me, I don't want to have injection. I am outpatient and I don't have any staff to help me at home or somebody. I want to take a tablet. Okay, I accept his position and I start with him. What we observe? First of all, we observe we can manipulate the dose. It should not be only 3 times per week. We can make it 2 times. We can make it 2 times with full dose, 1 time with less dose, depending on hemoglobin and complication. One important complication with him, it was the headache. And this headache not only because of the hypertension or hyperkalemia, what can occur with all, but it is also indirectly or independently from the blood pressure.
Thanks, Professor Muhammad. Any comment from our consultant and professors? Professor Hisham Said, Professor
Dr. Isa, I am waiting for your comment. Not only, I am really inviting your comment.
Thank you very much, Muhammad. Dr. Rohani. Jazakallah khair is an excellent lecture. Despite it's very simple, you can grasp it easily. It's very thorough and fully present the idea and the topics indeed. There's always a concern. Does the actual fortification of this molecule and its size related really to the adverse events that may occur, or that's not really a relation, it is a misnomer?
It is a question.
Yes.
Yeah, okay. Dr. Isa, the size of the molecule itself, you mean between darbepoetin and the other apoetin? Yes? Yeah. In this mean of the complication, there is no different complication of that, but the size of the molecule giving me prolonged life. Okay. And the prolonged life is leading to minimize the dose and effect and prolonged effect. I didn't read or didn't come to my mind that the length of the structured recombinant erythropoietin or darbepoetin is affecting directly the complication.
All right. In fact, we had a study published many years by our clinical renal pharmacist, where we did the conversion from APO to DARPA. And in fact, it was, the conversion was almost 1 to 400. And really the quality of life and the cost reduction was quite significant. Did you find that relationship as well at your centers?
Look, it is clear when we start to have darbepoetin comparing to erythropoietin, we have this point. First of all, less frequent to give the patient, either as outpatient or in dialysis. The nurse are happy. I must tell that because it is our nurse work. The most important, the cost is less. Clearly, the cost less with darbepoetin. Okay, because it is almost the same price, and I am using 1 compared to 3 nowadays. Okay, so there is at least 66 or 60% reduction of the price if I can calculate. I'm not looking to the price at that much, but yes, we reduce the number of the cost and the number of the puncture if it is subcutaneous.
Excellent. Thank you very much, Dr. Mohammed. I think there are other still questions in the web. Yeah,
yes, yes, Prof. كان في usually there is debate, Prof. Mohammed, regarding uses of erythropoietin in malignancy patient. Either this patient is in remission or this patient on activity. What about your experience regarding that?
I will tell you something. Erythropoietin nowadays not only used limited to the end-stage renal failure, but also such condition as chronic anemia related to chronic disease like canceroma is recommended. But we have to remember this clinical trial is not straightforward. Some is telling no effect, some is telling yes. Erythropoietin has another receptor in the human body, not only in the bone, and can aggravate the growth of cell and lead to the aggravate and increase of risk. So how strong to us in my center, I didn't find. I will tell you, I had in Yemen center, and I think Dr. Hisham know that in Yemen we have a large number in each center. And when we started darbepoetin, we didn't for many years we didn't have observed increase in the oncological issue. And here I have more than 45 patients in our center, no increment, or at least we did not observe that. However, there is still trial telling yes, there is some relationship between all the ESA and the oncological occurrence.
Professor Hisham, تفضل.
First of all, thank you very much. It's very enriched and illuminating. Just I will try to transfer my experiences in darbepoetin around 20 years in darbepoetin. Yes, it's a very efficient drug and the cost saving and can maintain what's called homogeneous hemoglobin all over the year. No evaluation for that level high and up, which is meaning that carry more risk that variations in hemoglobin. So I believe that darbepoetin is efficient. My comment for the, I will start from the end by the oncology. All of the ESA and the HIF will carry the possibility not as a probable of carcinogenic, meaning that new tumors, but on old tumors they can have, simply because all of these drugs, HIF and ESA, induce vascular endothelial growth factor, which is typically what the tumor do, and the new angiogenesis. So both of them will increase the angiogenesis and the vascular endothelial growth factor, that meaning that more risk for tumor. I think it's not advisable except in hematological malignancy. You can use ESA and darbepoetin, but solid organ tumor we have to avoid for probability of spreading out of the malignancy. Third point, and in very short brief, if you read recently the draft of the KDIGO guidelines 2025 of anemia, they make it more bothering because they specify the ferritin and the TSAT at the same step. So it can solve what is the, if you have a high ferritin from inflammations and we have a TSAT from unusable iron, and this is conflicting for the questions on the quizzes on the chat inquiries. So in the last draft of KDIGO guidelines, you can find on the same row, when the ferritin is above 200 and the TSAT 15, for example, you can give iron. And if you go up by the ferritin, you go up by the TSAT. Subsequently, I think it will be published very soon, but it's available online, the draft version that will solve all the puzzle between ferritin and TSAT values. Otherwise, I would like to thank you very much. I got a lot of information from your side.
Thank you so much, Dr. Hisham and Dr. Isa. Really appreciated comment, and I have nothing to add.
Thank you, Professor Muhammad, and we'll end this session and we'll transfer rapidly for the second session. Dr. Fadi Magdi Ilyas regarding personalized anemia care in CKD.
Hello, Dr. Atris. I'm so sorry to interrupt. First, I want to thank you all thank the Oman Society for the opportunity, and special thanks for Dr. Muhammad Rouhani for being with us and just making all the efforts for this presentation. Thank you so much, Dr. Muhammad. All Amgen appreciate your efforts a lot. Thank you. And I just have one small question. If we can just go back to the first slide, I just need for documentation. if possible يعني دكتور محمد.
حاضر يا ستي، هنعمل ايه؟
على راسي وعيني، شكرا، يخلي لي اياك.
هنعمل ايه؟
يخلي لي اياك.
طلباتك تكثر يا بنت.
والله، بس يعني بقول اني بمون عليك، بس يخلي لي اياك. شكرا.
حاضر. انا قريت الريمارك على الواتساب وعملت طناشه، بس ما فيش فايده، تعرف. اللي عايزاه لازم تعمليه. حاضر.
لا والله لا والله شكرا كثير لك وماتش ابريشيتد والله البرزنتيشن. طيب just بدي اخذ just a screenshot for the first and the second for the thank you so much.
خلاص.
تمام.
Okay, thank you so much.
تمام. Thank you doctor.
Thank you so much brother, and I hope we can see each other in the next future, and thank you all. Really, I am appreciating and happy to was with you. Thank you.
Thank you, Muhammad. Dr. Maha, you have anything or can transfer to second session?
I'm good. Thank you so much.
Okay. Dr. Fadi, تفضل.
Good evening, and thank you so much. My dear colleagues in the Oman Society of Nephrology and Transplantation, Professor Isa Salmi and all my colleagues. Thanks for the Egyptian Society of Nephrology and Transplantation, Professor Hisham and all my colleagues, and our colleagues from UAE and Nigeria, and all the attendees. Thank you for this meeting and giving me the opportunity to speak about this important topic. Thanks for Amgen for organizing this meeting. Without further delay, I will now move to my lecture about personalized anemia care in CKD. And as mentioned by Dr. Muhammad in the previous lecture, we have to personalize our treatment, and we have many options now for treatment of anemia in chronic kidney disease, whether dialysis, non-dialysis, and there are many options for treatment. With a challenge in anemia and CKD is that anemia prevalence increase with the increasing CKD stage, especially in dialysis patients, reaching up to 87% in dialysis-dependent CKD. And in fact, anemia itself accelerates the progression of CKD and increases the already high costs. In addition, anemia reduces the quality of life, cardiovascular comorbidities, which is already the leading cause of mortality in patients with CKD, in addition to hospitalization. And this slide shows that the survival of patients with CKD is related more or less to the hemoglobin level. And as you see, the probability of survival is less when the hemoglobin is dropping. So now when we are treating anemia in CKD, we are improving the survival of our patients. And this is really a challenge, but really an opportunity to improve survival, to find a modifiable factor to improve the survival of our patients, especially dialysis patients. For management of anemia in chronic kidney disease, in fact, erythropoietin is a breakthrough in treatment. And I remember when I read this paper in 1990 by McDougall and his colleagues, when they first published the first big study about erythropoietin, that was a breakthrough in treatment of anemia in chronic kidney disease. But it was associated with an increase in hemoglobin by more than 5 grams per deciliter and was associated with some cardiovascular and clotting issues. And this raises some questions about the use of erythropoietin in patients with CKD. So we're going to have some questions and answers. The main questions we are asking when, which, why, and how. When to use erythropoietin, and which type of erythropoietin should we use, and why we are using erythropoietin rather than other medications, and how can we use it. So let's proceed. When we revise the standard guidelines for KDIGO 2012, and I believe it will be replaced soon, maybe after a few months, by the KDIGO 2025, that the starting point is usually 10 grams per deciliter in non-dialysis patients, and all of us maybe agree about this. And for patients on dialysis, the starting level is 9 grams per deciliter, especially in special situation. However, they suggested in KDIGO that not to go above 11.5, and they recommended by strong level of evidence 1A that you will never go above 13. I believe all of you are familiar with this. But which EPO should we use? We are now having many options of erythropoietin. According to KDIGO, you should choose the erythropoietin based on the balance between the safety information, the clinical outcomes, the cost, and the availability of the drug. There is no one EPO medication or erythropoietin stimulating agent or ESA is superior than the other in raising the hemoglobin. But it is not only raising the hemoglobin, there are other points that should be considered in this point. Intravenous or subcutaneous administration can be used in hemodialysis patients. However, we prefer the intravenous. For the non-dialysis patients and the peritoneal dialysis patients, they suggested subcutaneous administration. And by the way, there is no use for the adjuvant to ESA treatment, including vitamin C, vitamin D, folic acid, L-carnitine, and pentoxifillin. There is no strong evidence for the use of these items. So now erythropoietin is the cornerstone of the treatment. Now I'll come to another question: when to use. Now, when we are having a level of hemoglobin, but I've searched about this interesting trial in Japan last year, and it was published in Kidney International Reports. They compared two groups of patients when they started at hemoglobin more than 9 or less than 9 in two major centers of dialysis in Japan. And as you see here, in the blue line is the group who has delayed treatment when the hemoglobin dropped less than 9, compared to this group when they started between 9 and 10. And at the end of the study, which was 2 years, the level of hemoglobin was almost the same. And in the second study, and in the second center, the same policy was applied using erythropoietin here on the low level between 8 and 9, and here between 9 and 10. And at the end of the study, the target of hemoglobin was almost the same. In fact, the primary outcome of this interesting study was the renal outcome and all-cause mortality. By the way, this study was on non-dialysis patients. The primary outcome for this study is a starting renal replacement therapy or a reduction of more than 50% in the eGFR from the baseline. And in fact, there was no significant difference between those who started less than 9 compared to those who started more than 9 grams per deciliter. However, a very important point in this study is that the cardiovascular composite outcome was significantly different. So the cardiovascular outcomes regarding hospitalization for ischemic heart disease, including myocardial infarction, stroke, and heart failure, and cardiovascular death, was significantly less in those patients who had early treatment compared to those who had late treatment. And this was applicable in both centers in a significant amount of patients over a 2-year observation period. So this is an interesting study showing that maybe if we started EPO early, we are getting a good outcome regarding cardiovascular disease, which is the leading cause of death again in our patients. And all of us are familiar with the QUAR study and the normal hematocrit study and all other studies that has shown that a very high hemoglobin reaching, for example, in the QUAR study to 13.5 is associated with a high rate of mortality, stroke, myocardial infarction, and hospitalization. So that's to say that we have to individualize our treatment and pick up a suitable starting point for hemoglobin and not to reach a very high level of hemoglobin to minimize, because our target is to reduce the mortality and improve the survival of our patients, especially regarding cardiovascular disease. Back again to erythropoietin stimulating agents, we are having three famous drugs, epoetin alpha and beta, the darbepoetin alpha and the continuous erythropoietin receptor activators. And these are the doses. I believe all of you are familiar with it. The darbepoetin has an advantage of being used once weekly or once every 2 weeks. And this is, in fact, a very important point, especially in patients on non-dialysis patients and peritoneal dialysis patients, in addition to hemodialysis patients. In fact, we are facing difficulties in giving epoetin alpha and beta in non-dialysis patient 3 times per week. It is not convenient to the patient, and we are having many patients missing to take the drugs. The continuous erythropoietin receptor activators can be given 2 weeks, every 2 weeks, or every 4 weeks. This is a shape of the erythropoietin receptor and the comparison between the short-acting erythropoietin, epoetin alpha and beta, and the darbepoetin. In fact, the secret behind darbepoetin is the presence of additional carbohydrate side chains. And this additional carbohydrate chains, in fact, is the key performance factor in prolongation of action and stabilization of the action over 1, 2, or even 4 weeks during treatment. This is the mechanism of action of darbepoetin, and in fact, all erythropoietin stimulating agents is by binding to the erythropoietin receptor, dimerization of this receptor, and the activation of Janus kinase 2 for gene activation and formation of growth factors and transcription, leading to formation of red blood cells from the bone marrow. The potential advantages in darbepoetin is that the carbohydrate content prolongs its half-life following intravenous and subcutaneous administration. So it's very good in patients who are having dialysis. We are in fact giving it intravenous in most of our patients, and can be given subcutaneous in outpatients, non-dialysis, and PD patients. The binding affinity for the highly glycosylated darbepoetin alpha is about 4.3-fold lower than that of epoetin alpha. So there is no strong affinity to the receptor, so it can move from one receptor to another, and this stabilize the level of hemoglobin even more than epoetin alpha and beta. And the half-life is longer. Therefore, it is available to bind to, activate, and release. Bind to, activate, and release from the EPO receptor for a longer period of time. And in fact, it's more convenient to the medical staff and patients. I have questioned many of the staff, of our nursing staff, regarding the use of darbepoetin compared to the 3 times per week, the prescription and the errors in the prescription and the dosage. All of these is favoring the use of darbepoetin compared to epoetin beta and alpha. And in fact, using it once weekly is very convenient. I believe all patients or non-dialysis patients should have a long-acting EPO rather than to receive multiple injections per week, keeping in mind that the leading cause of CKD in Oman, in Middle East, and even the whole world is diabetic kidney disease. They are already receiving multiple injections of insulin, and we are sometimes overloading them with multiple injections of erythropoietin. Regarding the SERA, or the continuous erythropoietin receptor activators, it's have a longer half-life, can be given once every 2 weeks or even every 1 month. And most of the studies were non-inferiority studies to other ESAs. Sometimes one drawback of them that the modification of the dose is less flexible to compare to darbepoetin. A famous trial compared darbepoetin to SERA is the ARCTUS trial, which was used in the CKD non-dialysis patient. And analysis showed that SERA once every 2 weeks was as effective as darbepoetin once weekly for correcting anemia. So there was no significant difference between them, and in fact, it was non-inferior to erythropoietin. The other study is the Amicus trial, compared the use of sera to epoetin, and also it was not inferior to epoetin beta, which was given 3 times weekly. Now I'll touch some points in the draft mentioned by Professor Hisham, the KDIGO draft of 2025. In fact, I have went through it, and it's really interesting, and I believe we have to look for some interesting points in the KDIGO 2025 that will be published soon. The first point is that we avoid adjusting the dose of ESA more frequently than once every 4 weeks. There is no point of adjusting the dose of EPO every week. It's of no use. The exception in this situation is when hemoglobin increases more than 1 gram in 2 to 4 weeks after initiation of therapy. So in fact, this is an important point to keep in mind, that frequent adjustment of ESA dose is not advisable. And also an important point is to use the lowest dose possible for ESA in general to avoid cardiovascular and clotting issues due to hypercoagulability and hyperviscosity. Another important point is to suspend ESA. This was a suggestion to suspend ESA during hospitalization for acute stroke, vascular access thrombosis, or thromboembolic events. And the target of the hemoglobin, in fact, is the same, targeting hemoglobin below 11.5. This point, in fact, has never been changed. And now we come to the debatable point about cancer patients. And they stated that in people with CKD, anemia, and active cancer, or a history of cancer, use shared decision-making regarding continuation or discontinuation of ESA therapy based on patient preferences and anticipated outcomes. So this point, in fact, until today, is not 100% sure. It should be also, we put it under the title, individualize your treatment according to the benefits and risk. In fact, yes, the growth factor and the angiogenic factors induced by the ESA can make cancer worse, and they can induce proliferation of cancer cells. However, treating anemia will reduce cardiovascular mortality. Another team may suggest giving blood transfusion for the patient. However, this point is not closed until today. Now I'll move to one case scenario to transfer our talking from theoretical point to a real life. This is a real life scenario. Mrs. A is a 61-year-old woman on maintenance hemodialysis for 6 years due to hypertensive nephrosclerosis. She's having 3 sessions per week, 4 hours each. Left radiocephalic epifistula, it's well functioning. Her dry weight is 62 kilograms. And she reports progressive fatigue and reduced effort tolerance, reduced functional capacity, and poor appetite. Her blood pressure is controlled. She's only on one medicine, amlodipine, 10 milligrams per day. So now when we looked at this patient, she's complaining from symptoms suggestive of anemia, fatigue, reduced effort tolerance, poor appetite, and reduced functional capacity. When we checked the lab results, we got a hemoglobin of 9.5. Another reading was 9. Ferritin 420, which is maybe okay. Transferrin saturation 26%. Albumin 34 grams per liter. CRP was slightly elevated, 7. The normal level was up to 5. And the KT over V was 1.1. She was getting darbepoetin 60 microgram per week, and this dose is adjusted based on response, and iron sucrose 100 milligrams every 2 weeks, adjusted dose. So I have 3 questions. What is the potential cause of her symptoms? And are the dose of ESA and iron adequate? And is there any further workup needed? So the message behind this case is not just to increase the dose of darbepoetin or other ESA, because sometimes when we are encountered by such case, some of our colleagues are rushing to increase the dose without looking about other causes or other potential causes of her symptoms. I believe the dose was okay. When we reviewed the causes of erythropoietin resistance, these are the familiar and common causes: inflammation, There was no inflammation despite a slightly elevated CRP. This can be a normal finding in patients of chronic kidney disease without an active going infection or inflammation. Iron deficiency is not there. Hyperparathyroidism, in fact, was not there. There was no bleeding. Folic acid and vitamin B12 was normal. There was no active malignancy. And the patient was not on any drug known to cause anemia, such as angiotensin receptor blockers. She was on amlodipine. Now we are having the KT over V for this patient is 1.1. And in fact, this patient had an inadequate dialysis. And in this patient, when we improve the dialysis adequacy on the same dose of darbepoetin 60, hemoglobin improved to 10.5 and maybe approached 11 grams per deciliter on the same dose of darbepoetin. So it's a very important message to search for the cause of hyperresponsiveness to darbepoetin or any other ESA before rushing to increase the dose. And in fact, KDIGO guidelines in 2025 addressed this nice figure showing the causes of anemia in CKD rather than erythropoietin deficiency, including hemodialysis-related bleeding, GIT loss, malnutrition, and deficiency, B12, bone marrow disease, hyperparathyroid and hypothyroidism, and all other related disorders, including malignancy. So this point is to be considered in all patients with ESA-resistant anemia. In fact, when I revised the KT over V figures of our patients in the GCC area published in 2021, I found that maybe 1/3 of our patients are getting a low KT over V dialysis, inadequate dialysis less than 1.2. I believe that about 30% or more in Oman and other neighboring countries are receiving lower doses of dialysis required. And the blood flow rate, the percentage of patients having a blood flow rate less than 300 is approaching 50% of our patients. So now I'm getting to a very, very important point is the correlation of dialysis adequacy with the treatment of anemia. Treatment of anemia is not just EPO. You have to treat the patient as a whole. And one of the most important points is provide an adequate dialysis for the patient before rushing into increasing the dose of EPO. I have a few points about iron therapy in CKD because if the patient is iron deficient, giving erythropoietin is of no use or of little use. And as you all know that patients on dialysis or CKD, according to KDIGO, should have an iron therapy if the T-sat is less than 30 or the ferritin is less than or equal 500 nanogram per milliliter. In KDIGO 2025 draft that will be published soon, now maybe it became more complex in patients that are not having dialysis. When the ferritin is less than 100 and T-sat is less than 40%, or ferritin less than 300 and transferrin saturation less than 25%, and in those receiving dialysis, ferritin less than 500 and T-sat less than 30, treatment of iron deficiency should be considered. So if any of these is present, we will proceed for iron treatment. And if not present, we will perform a full anemia screening before going for iron replacement or ESA. So again, I'm repeating, check for other causes and check for iron deficiency before increasing the dose of darbepoetin or other ESA. Again, what dose is suitable for iron? Is it a high dose of iron? Keep your patient with a high level of iron or a low level of iron. This very important study, which is a pivotal trial published in 2018, compared the proactive high dose intravenous iron to the reactive low dose intravenous iron. The proactive iron was 400 milligrams per month and withhold if ferritin is more than 700 or T-sat is more than 40. And the reactive iron to give IV iron only if the ferritin is less than 200 or transferrin saturation less than 20. And as you see here, in the patient with the proactive high iron dose, the level of ferritin approached 600, while in the reactive low dose group, only from 150 to 200. And in fact, the cumulative EPO dose in patients having a reactive low dose iron was high. So these patients having low dose of iron on the contrary, received a high dose of EPO with more side effects of EPO. And patients having proactive high dose of iron had a median monthly doses reduced by about 20% compared to those with reactive low dose iron. The primary endpoint of the pivotal trial was the death, myocardial infarction, stroke, or heart failure and hospitalization. And as you see, there was a significant difference between the patients having a proactive high dose iron compared to the reactive low dose iron. So another point to be considered, keep your patient iron stores and iron transferrin saturation of an adequate level to maintain a good action of darbepoetin and ESA. Another important point for iron is the infection risk. In fact, the pivotal trial didn't show any significant change regarding infection in giving intravenous iron in a higher dose. Yes, it's agreed that during active infection or active bacterial infection, it is not advised to give intravenous iron. However, iron itself doesn't increase the risk of infection per se. In terms of iron therapy, we're having the old agent, iron dextran and sodium ferric gluconate and iron sucrose. Iron sucrose that we are using in most patients in Oman, and the newer iron preparations, ferromoxitol and ferric carboxymaltose, now we are using in Oman in limited amounts, and is giving a higher or better results, but of a higher cost. Regarding the oral iron preparations, can be given in patients not on dialysis, CKD not on dialysis, as a trial, as recommended by KDIGO, including ferrous sulfate, which is also our famous drug here in Oman. We're using for many patients. Ferrous fumarate, ferrous gluconate, and ferric citrate, which is a phosphate binder as well, but it's an extremely expensive drug, costs about $8,000 per year. There is a controversy about iron therapy, and I believe one of our colleagues asked a question in the previous lecture about the serum ferritin and the transferrin saturation. In fact, serum ferritin, when elevated, does not always correlate with elevation in liver iron content. And this was raised in the KDIGO meeting report, the controversy report about iron management in CKD. So hyperferritinemia is thus not synonymous with iron overload, because the patient simply might have an infection or an ongoing inflammation because of acute phase reactant. And in fact, high transferrin saturation facilitates parenchymal iron deposition. And in fact, transferrin saturation reflects the iron level in the patient more than the ferritin level per se. And when we are evaluating ferritin level, we have to keep in mind the hepcidin and the inflammation. Hepcidin or hepcidin is high in patients with CKD, especially during inflammation or infection. And we know that hepcidin will reduce iron release from the reticuloendothelial system and macrophages, and decrease iron absorption from the intestine. And thus, this is also one cause of erythropoietin resistant anemia, the inflammation and the higher level of hepcidin. Now I'll come to the final part of my talk. It's about the HIF stabilizer or the hypoxia-inducible factor stabilizer. We are not going into more details about this, but because the new KDIGO guideline will put it in patients having erythropoietin resistance in somehow. So as we know that the hypoxia-inducible factor is degraded by the HIF prolyl hydroxylase enzyme, or PHI, or PH, the prolyl hydroxylase. And in the presence of hypoxia, the HHIF prolyl hydroxylase enzyme will be inhibited, leading to gene transcription and increasing the amount of EPO, increasing iron absorption, reduce of hepcidin level, and also increase the iron transport to the bone marrow. All of these will increase the red blood cell production, making it an attractive way of treating our patients. In fact, HIF-PHI inhibitors or HIF stabilizers will increase the divalent metal transporter 1 in the intestine. It will improve the absorption, will reduce the hepcidin level, will increase the transferrin, will increase the transferrin receptor even, and will stimulate the erythropoietin receptor, all of which will lead to increased erythropoiesis. And there is attractive point in this medication that they are given oral, and it's a positive point for patients who are non-dialysis patients. This famous trial compared daprodustat, which is one of the HIF-PHIs that found non-inferior to erythropoietin-stimulating agents when giving to patients undergoing dialysis. So it was non-inferior to erythropoietin-stimulating agents. There are many trials for the daprodustat, the roxadustat, the vadadustat. I will not go into the details. It's not our topic today. But the most important point is that in the new KDIGO guidelines, we will consider 3 to 4 months trial of HIF-PHI or HIF stabilizers in patients having hyperresponsiveness to ESA. So this algorithm will move from hyperresponsive to ESA to search for identifiable cause. If the cause is not identified, but hyperresponsiveness improved, we'll continue monitoring. But if no cause identified, we have to try 3 to 4 months trial of HIF-PHI or transfuse even patients that is clinically. So we have to put in mind this point. I believe this will be approved soon, and we'll put it in our algorithm. The HIF stabilizers in this study was at least as erythropoietin alpha for lowering the risk of major adverse cardiovascular events, which is again the leading cause of death in our patients. But there are some safety concerns about the hemoglobin rise. And as you see in this study, which compared the roxadustat to ESA, there was a sharp increase of hemoglobin in this patient compared to patient received ESA. And this might be a concerning point that the FDA have withdrawn some of the medications and then reintroduced back again. So does it mean that it's a new drug? It's an angel? No, it might have some concerns and some potential safety concerns. I'll summarize it in some few points. The thromboembolic complications, including pulmonary hypertension, and long-term oncogenic risk is unclear. It remains unclear the oncogenic risk of HIF stabilizers. The proangiogenic effects can negatively impact retinal disease and also may be involved in renal fibrogenesis. The relation between infection, sepsis, and GIT-associated symptoms are still some safety concerns about HIF stabilizers. And once rejected, now FDA approved for CKD-related anemia. And they are not the first line in treatment of anemia, and there is no clear suggestion of using HIF stabilizers as the first line. And still, despite the FDA approved the product set for anemia of CKD, however, it is not the first line. Finally, some recommendation from the KDIGO draft 2025 that we don't use ESA and HIF stabilizer, HIF-PHIs in combination. And in people with anemia and CKD, we can administer HIF stabilizer at the lowest dose with the same policies that stand for ESA. And in people with anemia and CKD, we have to discontinue HIF-PHI after 3 or 4 months if the response has not been achieved, and we will search for another cause of hyperresponsiveness to ESA. It's wise to suspend treatments with HIF stabilizer in those who experience cardiovascular events, because I have just said there are some safety concerns about HIF-PHIs and from thromboembolic events, and it's wise to suspend treatment in these patients. And finally, in patients having ESA hyperresponsiveness, after a trial of 3 to 4 months after initiating the drug, if there is still hyperresponsiveness, you should discontinue treatment. This is my final slide. It's a summary by KDIGO, and it's nice and simple. And I believe our practice is like this. We are starting with checking iron stores, ferritin and transferrin saturation. We'll perform full anemia screening for other causes of anemia, including vitamin B12, folic acid, CRP. And we'll start IV iron therapy if there is an iron deficiency. If it is corrected, we'll start with ESA. ESA still the gold standard for therapy. Alternative HIF, PHI when preference for oral agent or cannot tolerate ESA for other factor, but the gold standard is ESA. And in patients with ESA hyperresponsiveness and you cannot find a correctable cause, 3 to 4 months of HIF stabilizers can be tried. Thank you so much, and I am ready for any questions, and thanks for letting me to share this lecture with you.